Okay, so I'm going to get started with my introductions while people start joining. And I just want to say on behalf of UCSF and the San Francisco Bay Collaborative Research Network, I'm very excited to welcome you to what we hope will be the first installment of a series of webinars related to COVID-19 and its impact on primary care and primary care research. As you know, SFBayCRN is UCSF's primary care practice-based research network supported by the UCSF Clinical and Translational Science Institute. And we facilitate academic and community research partnerships that advance our understanding of clinical practices that can improve health outcomes in diverse communities. And in addition to educational meetings such as this webinar, we also provide consultations to researchers seeking to develop such partnerships through our SFBayCRN website. My name is Michael Potter, and I'm a professor in the Department of Family and Community Medicine at UCSF and the director of SFBayCRN. And I also want to introduce Saji Mansour, our new SFBayCRN program coordinator, who's really, in a few short months, been making his impact felt on our activities. Please reach out to either one of us if you're interested in learning more about our network. And so now I want to also thank you all for joining us today to hear Dr. Rebecca Etz, who will speak on the topic of COVID-19 in California safety net settings, learning from the experience of primary care clinicians and their patients. Dr. Etz is a professor of family medicine and population health at the Virginia Commonwealth University and co-director for the Larry A. Green Center in Washington, which is dedicated to advancing primary health care for the public good. Her career has been dedicated to learning the heart and soul of primary care through two main lines of inquiry. First, bridging the chasm between the business of medicine and the lived experience of the human condition with research that demonstrates the integration of medicine within the fullness and dignity of humanity. And second, exposing the ways in which current trends in healthcare transformation and stakeholder engagement fall short of their desired goals to bring the worlds of medicine, public health, and communities together in collaboration for improved population health. Early in the pandemic, Dr. Etz realized that it would be important for policymakers to understand the impact of COVID-19 on primary care clinicians and their patients. And to this end, she developed a sentinel network of primary care clinicians and patients who have answered monthly surveys about their experiences throughout the pandemic. SFBayCRN has supported these activities, and many of you may have participated in some of her surveys. And so now it's my great pleasure to welcome Dr. Etz to share some of her results, some of which give us a national view, some of which drill down into our experiences in California, and some of which also give us insights into what has been happening in safety net settings and for patients who are served in those settings. As I turn it over to Dr. Etz, I want to invite you to share your questions in the Q&A. Everyone will be able to see your questions, and you can respond to the comment on the questions or upvote them. I will be facilitating the Q&A afterwards, and we'll try to make sure to get to all the questions, if not during this webinar discussion, afterwards. After maybe we can get answers to your questions afterwards. And then the other final thing is that when you do log off from this webinar, there will be a brief survey where we're going to ask you some questions to help us plan for future meetings, and we hope you'll participate both in answering those questions and our future program. So, and now I'd like to offer a warm virtual welcome to Dr. Etz.
Thanks so much, Mike. I really appreciate it. It's a pleasure to be here. I love being able to share the work that we've done, because any chance to give a voice to all the time that everyone spent sharing their information with us is such a privilege. I call this talk Where the Sidewalk Ends, and I'm not trying to be cliche about, everything you learned in kindergarten is everything you need to know, but I really do love this book. So Shel Silverstein is a poet and an author, and he wrote this book Where the Sidewalk Ends, and it is a bunch of poems that really captures the wonder and innocence that children have as they encounter the world. And this is one example where, you know, when they get to the end of the sidewalk and there's an edge, they have an imagination about what's on the other side. And it isn't like jumping off a precipice. It is a world of possibilities. And, you know, whether we like it or not, I kind of think that's where we are with primary care now. We really are at the edge, and we can either be, you know, all hunkered down and upset about it, or we can think about what's a different way of seeing this. What are we learning and how do we move forward? So I say that because I'm going to share some stats that are kind of sad and disturbing, but hopefully we can look at it in terms of where we are now, where we need to go. So as Mike mentioned, our center focuses on the questions that need to be asked of primary care and how we advance primary healthcare for the public good. So we often spend time thinking about not this very moment and not you know, our grants or publications or interactions, but what's coming down the pipe? What's the world out there, and are we paying attention to it, and what do we see coming? And we were doing that on March 13th when the public health emergency in the US was declared. And we were just talking to each other about the fact that our country has anemically supported primary care for decades now, and we have no anything. We have no national office, no national database, no information exchange that would let us know what was going to happen in our country as this pandemic hit. It was going to affect primary care dramatically, but how would we know? So we knew we needed to develop a network. It may not be the best, but we knew we needed to get started right away. We had to gather data directly from people in practice, not as we could attempt or back in from other places. And we needed to provide primary care with an outlet, access to their own data and an outlet for their voice. So we decided on a survey. We wanted to do something quick. It should help, but it shouldn't hurt. I think it probably still was a great commitment of people who take the survey. So for those of you out there who have, really thank you. But our commitment to our partners in the beginning, it was a weekly survey. So we limited it to 3 minutes to complete, and we only included the data we could immediately make use of in the next week or two. As the survey continued on, it became monthly. So now they take about 4 to 5 minutes. The surveys shift. The questions are not consistent over time. They are responsive to the pandemic as the pandemic moves over time, and they were responsive to the practices that participate. So we have 3 different kinds of questions. These basic demographic questions that allow us to do some interpretation or context sense making of the information we receive. We have flash questions, which, as I keep saying, is not a thing. I made it up, but I was thinking of flash mobs, you know, something that's there, impactful, and then gone. And so we do that in relation to the pandemic. And then we have clinician questions. We always ask our respondents if there are things that they would like to ask, and we include those as the very first question on the survey as a way to provide a service. I hope we'll have time at the end of this presentation to ask you all if you have questions that you would like to see. The spacing on this slide looks funky, but you'll understand that in a moment. This is going to be posted, so I'm not going to bother going through all the distribution stuff. I really wanted to give you a sense of the breadth. So we've collected about 50,000 surveys since the start of the pandemic. We have about 14,000 of them among patients, and the rest are among clinicians. And since this presentation is for you all, we tried to pull out our specifically California and FQHC information. So in terms of sample size, for California, you all have participated in the survey since the beginning, usually between 40 or 50 responses per survey. We did have some large spikes in the beginning. Those spikes would be during the weekly surveys when things were pretty bad. Around October of 2020, we started paying attention to FQHCs in particular. Before that, we were actually tracking CHCs, but not FQHCs as a separate category. Because of the kind of network you guys are, I pull up a lot of FQHC specific information in this presentation. We do have participation specifically from your network. It wasn't statistically large enough for me to draw conclusions from it, but I wanted to let you know that we have it and it contributes to the larger whole. So I'm going to go through some things. I'm not going to talk a whole lot about payment. I think a lot of people talk about that. A lot of those questions are obvious. I want to talk about the impact on primary care and the kind of strain practices are under right now. With the one question that we ask consistently over the course of our survey is, how would you rate your pandemic-related stress over the last 4 weeks? On a scale of 1, none at all, to 5, severe. And what you have on the screen here is the severe to near severe. What percentage of people said their stress was severe or near severe? The colors will be consistent as I present. There's a gray line that represents the national average. The blue is California specific. And then when we have the information, we have orange for the FQHCs. Again, remembering that we started paying attention to FQHCs in October of 2020. So you see in the trend that we have a regular downward trajectory, which is a good thing. And then there's this weird thing that happens right here around series 30. That's July and August of 2021. What happens here is the vaccine, and then it's followed by Delta. So you see that practices start to gain some hope, and we have discussions of the vaccine. We're starting to gain hope and feel well. And then when we get our first evil variant come along and really upset things, it takes us back up to hard times. It makes us realize this is going to go on for a while. And so the stress levels stay pretty high. Now, if I were to zoom in just a little bit, what you will see is now I've expanded. So I've gone from October to the present, and I'm showing you California versus FQHCs. California, as you saw before, mirrored pretty closely with what the national average was. So I thought it was interesting to take a closer look at the difference between FQHCs and the national average, or FQHCs in the state of California. And what you'll see is not unexpected. Generally speaking, the FQHCs feel the strain more acutely. Almost everything that we see, FQHCs feel slightly more acutely. The difference here is not a small one. That's a 10% gap. I also want to remind you, in case people out there need to know, our primary care workforce is actually a top-heavy workforce. That is, we have an unusual number of our percent of our workforce population in the baby boomer generation. So they've been around for a while. So when they say that my stress is severe or near severe, and it has been for a long time, they are doing that with an understanding of what the past 20 or 30 years was. This is an unusual moment, and I'll get back to that. So there are other ways, very concrete ways in which practices are stressed, and one is meeting people. The workforce is shrinking. For a healthy primary care workforce, for a healthy platform, healthcare platform in any country, we know from our research that we need at least 40% to be primary care. When we entered the pandemic in the US, it was about 32% in primary care, and graduating medical classes were about 10 to 12% on average primary care. So we were already shrinking. We were below the threshold and already shrinking. And I want you to keep that in mind, because now look at the added and almost synergistic in a negative way stresses that happen. The first is people start going out ill. Now, this big upward trend you see of people being out ill was a lack of PPE. There was a period here when California was doing much better than the rest of the country. You had more access to PPE than the rest of the country did, and you had fewer people being out sick as a result. We have now settled down. We're about at 19%, but that's still 1 in 5 in a practice is out due to illness. That's a large percentage of your workforce to be missing at a moment in time. Then we add to that, during the pandemic, we have had people quit or retire early, largely because they are not getting the support they need, and the hours are long, and the work is very difficult. It is mentally draining in a way we've not had before in our generation. We started asking this question about a year ago. Do you have personal knowledge of people who have quit or retired early? And at that point, about 12% of people were telling us, yes, they did. As you see, California and the US map, they basically share the general same percentages. It starts to split off a little differently as we get into the latter part of 2020, and it's spiking up. 63% of people have personal knowledge of clinicians who have quit or retired early as a result of the pandemic. So if you can keep this in mind, you have a practice in which 1 out of 5 is out because they're ill. And now we have at least another, if not 2 others, missing because they've quit or retired early. We add on to that this third category, which is we have open positions we can't fill. We can't find bodies to do it. And again, you'll see California and the US, the trajectories are about the same. We started in July when we first started asking that question, and it was 22% of people who reported that, but now it's close to 60. This level of dip in the workforce is pretty dramatic. And I get asked often how many practices have closed during the pandemic, or how much shrinkage have we had? Can you put a number on it? And like I mentioned before, we don't have any national database. We don't have any national office, so we don't actually know. But we do know that this survey, which does appear to represent what primary care is experiencing, says that 63% of people know clinicians who have quit or retired early. 60% of practices have open positions they can't fill. And we also know, which I'll show you later, that 50% of practices report they're getting new patients because patients don't have their original practice, it closed. So we can understand that the size of the shrink here is pretty big. Now, I did briefly look at what FQHCs looked on these same 3 charts, and I was surprised to see that the quitting was actually the same. I would have thought, because it's harder in FQHCs, that you would have seen more of a drop-off of personnel. We do see more people getting sick. We do see that it's harder to fill positions, but the quitting and retiring early appears to be the same. What does it mean for practices then when we have this reduction in workforce? Something's got to give. What is it that gives? So this is what I was telling you before. California, again, is in the blue. National is gray. We don't have FQHCs on here just yet. We see this is the 40% line right here, just to orient you to the graph. So we see new patients from closed clinics, that there are 40% of practices are seeing that. In California, you're doing a little bit better than the national scene, which is nice to see. Many of these, California is actually doing a little better, right? Because these are hardships, so we'd want to see you smaller if we could. We see, though, that we have 15% of people reporting that they are using telehealth, not because they need to for clinical reasons or because of patient requests, but because they don't have enough staff to room patients. We have practices that were offering the COVID vaccine, but no longer do because they don't have the staff to dedicate to that. We have clinicians who are doing more non-billable work, spending half their time doing non-billable work because they don't have any staff to do that work. That's a tremendous expense that a practice doesn't usually incur. If you think about it, you're paying them a whole lot more to do the same kind of work. Although practices have expanded their hours, they're seeing fewer patients than they did before the pandemic. About a third of them are seeing fewer patients. Many of them are paying staff salaries they can't afford. And largely that's because we have a shortage of people, so that's what the market will bear, but it's not a pressure that we can hold on to, afford to maintain for very long. And then we have stopped quality improvement initiatives. About 20% of practices have stopped doing that. There are other things that they have stopped as well. It's about the same percentage of practices that have stopped participating in educational activities. They've stopped participating in research activities. You start to see what the priorities are. And, you know, I'm a researcher, but I actually think that's pretty good. What practices are doing is they're prioritizing patient care first, and then all the other stuff next. Now, if we look how the FQHCs compare here, in many cases, they look roughly the same, but there are 4 that I've highlighted for you here that are hitting FQHCs far more than they are hitting California in general, and a bit more than they are hitting the national scene in general. In particular, we are seeing far more of them are receiving patients that need someplace to go because their practice has closed. Far more of them are using telehealth because they simply don't have the human bodies to room patients, which then, of course, matches up with using clinicians for more non-billable administrative needs. What about patients? Equity is incredibly important. It always has been, but we've just sort of newly discovered it again. What are we noticing? Practices report to us about how their patients are doing. And here, California, National, and FQHC, what we see is clinicians reporting that their patients' mental health has gotten worse during the pandemic. Not surprised that we see that happening more in FQHCs. That their patients are having more financial struggles. So this isn't just practice saying our patients have financial struggles, but they're identifying that these struggles have increased since the pandemic started. Food insecurity has increased and housing insecurity has increased a great deal, especially among those who see FQHCs. Now, if we take that idea, and here I've taken 2 points at which we've gathered that information, once in November of 2020 and once in December of 21. And I say, okay, what do we notice about these particular social drivers of health? And although the job loss has gotten better in 2021, we see that they are within reason close to the same. Things have gotten a little worse for each category, but within reason they are similar. The next thing that's sort of natural to ask is, if clinicians know that, are they then also doing extra in their practice to help people with this extra burden? And you may look at the numbers that I share with you and say, what do you mean less than 30% of practices are helping with this? I want to remind you, these very same practices that aren't getting paid well, that have people out sick, that have lost people to early retirement, that have open positions they can't fill, have, in response to seeing the pressures among their patients, expanded services in response to that. So what we see is within California, this line here being November 20, and the darker being December 21, we see in California that there is an increase in practice reported support of food insecurity. So practitioners are actually helping their patients with food insecurities, with housing insecurity, with job loss. Most often this comes as waiving copays or waiving fees or just forgetting about your bill entirely. And with mental health, a tremendous number of practices have added on mental health support for their patients. So you can, and I want to point out that the scale here is the same, and I did that on purpose so that you could see they're trying very hard to match where the needs are, but with the social drivers, there's only so much that they can do. The blue is California. Now for FQHCs, we see a similar story, although you see with the FQHCs, they start to increase in 2021, and they maintain that increase in 2021, as opposed to practices in general. And then if we see that against the national scene, we see that everybody basically, they did what they could for financial insecurity or job loss. They put what they could into mental health first and tried to help with substance use. And then food and housing was something that they took on about 25% of the time, the best that they could. This was actually really amazing to see. And it is a way of understanding how clinicians see the social contract that exists between them and the population. Put your patients first, their needs above all else, and then we'll figure it out. And honest to God, primary care has been doing that for the last 2 years. And it's about time the payers and the government community woke up to that and started helping them out. What else did the strained workforce do? Well, they actually increased a lot of services in order to pull off some of the drain on tertiary and specialty care. So when we asked what sorts of things they were doing, we asked specifically, were you doing this with the explicit purpose of protecting tertiary and specialty care? And internally, they were doing many things to do that. The most popular among them was they were monitoring COVID positive patients at home rather than sending them to the hospital. For many, that was a daily call. They were extending services in their practices beyond their norm. New full scope primary care became more of a thing during the pandemic as clinicians took on procedures and other types of services that they didn't usually offer to prevent people from having to go to tertiary or specialty care. And they shifted their workflow as best they could to expand access, even though they knew there was a shrinkage going on. That was all stuff inside clinic walls, but you also see the commitment outside of clinic walls. And I really want to point out, this is 40% here. So more than 20% of clinicians, despite being hard pressed, despite working in the shortage, despite, they're volunteering at mass vaccination sites on their off hours. They are publicly speaking out about COVID-19 and how to help yourself and others around you. They are increasing or adding on hospital time that they didn't used to have in order to help the hit that the tertiary workforce was taking. I think we often neglect the impact that primary care has had on the rest of the system. But what do patients say? So you're seeing all of this first. We haven't put out much of our patient-reported information yet. We have some on our website. I took a sample of the surveys that we have. Every patient survey that we have gets at least 1,100 responses. You'll see in 2021, in addition to the 1,100 responses that we typically poll to represent the diversity that we see in our census, in 2021, we also had an extra 500 to 600 people that we oversampled that were either low income or rural, so that we could understand how those who were in shortage areas or those who were more vulnerable were being affected by the pandemic and what they would report. In some cases, I do actually report what patients specifically in California say, but as you can see, the numbers are small. So I would hesitate to take any implications of a California specific population from that. This first slide is the only one that's kind of screwy in colors, and I'm very sorry for that. I'm not at all excited about it, but I really wanted the information up there. This is looking over time. So we're moving from May of 2020 to August 2020 to December, and then to looking at what December looked like in California in particular. It gives you an idea of the kinds of visits people were having. So we had about 15 to 20% video visits. We had about 15 to 20% phone visits. And then we had in the beginning about 20% that were in face-to-face visits, and we've gotten as high as 40% face-to-face visits among patients that took our survey. Now, what you see is that the numbers jump around a lot. The face-to-face, we expect that to go up. It's interesting that it's lower in California. That's a big enough dip with our sample size that I would start to wonder about that. Some of you out there may have ideas about that. The types of visit, wellness, chronic illness, specifically COVID or other acute symptoms, they've kind of stayed steady. There hasn't been much movement in there. I was actually expecting to see some more, but I was surprised that even back in May of 2020, 40% of people were still reporting that they were going in for their wellness checkups. When we asked for open-ended comments, many of them told us they were trying to support primary care, which is great. We also got the opposite. People who said they weren't going to see practices because they were trying to give them some breathing space, not realizing that it meant that they weren't having the billables in the workflow. Patients also reported what happened when they got sick with COVID. Now here, of our sample, only a certain number of people actually were positive for COVID. And so these represent a smaller sample. I put the sample size in the top. We look here at the number who were hospitalized in May of 20, in August, and then in December. So in the beginning, we didn't have as much nationally. We started to ramp up. We all know and expected this, that we actually have started to see a resurgence of hospitalizations now, as you know, but we also know that people who are diagnosed positive in the hospitals now are often not going in specifically for COVID, but they're in for other things and then testing positive. So I stopped paying attention to it in December of 2020, because then it became a little harder to analyze. So we had, if we look in May of 2020, we had about 18% of people being hospitalized. We had about 42% of people staying home. Okay, so these are hospitalized and staying home. Now, once you were sick, once you were home, what happened? Who followed up? We have a lot of discussion in the media about hospitals and health departments, but when we asked the question of patients, what we found is it was really their primary care doctor who was doing more of the follow-up than anybody else. And in fact, the bar was pretty high for this one. We didn't say, did your doctor call you when you were homesick with COVID? We asked if your doctor was helping to coordinate your care as you were homesick with COVID, as well as following up. So you can see it's it's 3 times as much actually as reported of hospital follow-up, and at least twice as much as reported as health department follow-up. Patients also reported the different ways in which you guys were there for them. And this can't be understated. If you just ask blanketly, do you have a doctor that you trust? You get often numbers as high as 86. I actually picked the low point here to say that even at the lowest point, the belief in primary care was pretty strong. We tend to think that people don't believe in primary care anymore. We tend to think that they don't care, that they like anonymity and convenience and relationships don't matter. And the patients just told us over and over again, and at least 30% of them were under the age of 30. So this is not a generational thing. 70% have a doctor that they can trust. Someone that helps them to make sense of things going on around them. Many specify they can ask their doctor anything, even if it's not medical. That number spiked pretty high when George Floyd was killed. And they generally feel like my doctor knows me as a person. Now, only 50% actually said my doctor knows me as a person. And that's why I say that primary care is trusted. It's strong, but it doesn't run deep. And that difference between the 70% who can trust their doctor, but the 50% who feel like their doctor knows them, may well be some of the discrepancy we see about a doctor's ability to convince a vaccine hesitant patient to actually take the vaccine. That gap in relationship is not one about trust, but it is about knowing somebody at a basic level, and it matters for such personal decisions. We also see that patients report they're getting full scope care. And when I asked them if they were getting, if they experienced primary care as first contact, we spent a couple of sentences defining what that meant for them. So it was in layman's terms. And 74% said even during the pandemic, primary care was their first point of contact with the health system. 70% of them were experiencing comprehensive primary care, which we defined for them even during the pandemic. You all were doing that even during the pandemic. They had longitudinal relationships on which they could draw. They got to meet with their personal clinicians. Their care was coordinated. We can understand there's a dip in the coordination during the pandemic. Lots of coordination fell a bit during the pandemic, but it was integrated, and most importantly, it grounded them. It made them feel rooted and known and connected to something, which during the uncertainty spawned by the pandemic was a big deal. In terms of preference, this was one I really hope, if you're listening to nothing else, if you zoned out because this is your 87th Zoom call today, please pay attention. Where do patients want to get care? We often make the mistake and think that what people have purchased is what they prefer. It is not, and that's particularly not true for primary care. They purchase what they can get within a set of constraints. It is not necessarily what they prefer. So when we asked people what their first choice was of location to get primary care, the large percentage of them, the largest by far, said a traditional clinic. The next percentage, which is just 12%, is having a clinic on my job site. Urgent and walk-in was next in line. Retail, which we described as CVS or Walmart. Online, virtual only. Concierge practice, which we also explained was 24/7 access to your clinician. And of course, the emergency department. Then when we said, where did you actually get care during the pandemic? This is what they said in order of percentage. So the traditional clinic is still where they went the most, but take notice that urgent care was next and the emergency department is next. That is not where people would prefer to get their care, and certainly not in the order they would. It was where access could be found. So these things are different. What they actually purchase is not the same as what they prefer. Now, one of the things as a last note, because then I want to get to open up and hear from you all. The Green Center, before the pandemic, we created a primary care measure. I have it here on the screen. It's called the Person-Centered Primary Care Measure. It's 11 items. It's very brief to complete. It was a 3-year stakeholder process. We used 10,000 comments from hundreds of patients, from hundreds of primary care across all disciplines. We did a tremendous amount of work. It's now NQF and CMS endorsed. It is in the physician fee schedule. You can use it this year for your MIPS reporting. It is validated in 30 languages. It's on our website. I offer the link here. It is free for anybody to use. Now, the reason why I bring that up is because the 11 items talk about full scope primary care. There are a few things that are not in the instrument that I wonder about, that we believe is embedded within the instrument, but it's not specified, and it's stuff that comes up a lot. And so I wanted to ask patients about it. We've done this twice. So what I'm reporting here are percentages from a patient sample size of over 2,000. And we asked, if we put a statement, my doctor is worthy of my trust, and then we asked people to state whether this was something they had, which I will show appearing in blue, whether it was actually important to them, which I show in orange, and this affects, they believe that it also affects the quality of care, which I show in gray. So the first one is my doctor worthy of my trust? The scale will be the same as I go across. I don't put 0 on because nobody said 0, of course. What you'll see is that 80% of patients said that their doctor was worthy of their trust. This matches up really well with the people who said, I have someone I can trust, right? So we like that. That's triangulating, that's good stuff. A little over 90% said it was important to them. So right away, we see the gap between what people actually get and what's important to them. The thing that I was pretty surprised by, and I'd be interested in your thoughts on it, is that when we asked, do you think having a doctor worthy of your trust actually affects the quality of your care? A smaller percentage thought it affected the quality of your care. So if we're trying to evaluate the quality of care, is this a question that we ask or not? So 80% have a doctor worthy of their trust, 91% feel that it's important to them, but only 86% felt that it actually affected quality of care. What about feeling safe? I feel safe being vulnerable in front of my doctor. Wow, much fewer, it's about 76% say that they actually have this. And for many of them, it's not as important. It's important to me. I was shocked about this one, but look at the percentage for those who think it affects quality of care to feel safe. only 66% actually think it affects quality of care. I am respected by my doctor. Again, I don't know why such a small number. It's above average, but still, it's sorry, that one's 66, the pre-one was 69. It's still a fairly small number that say it's important to them, but I was glad to see that 80% of people felt like they could endorse this comment. I was a little worried about the fact that a smaller percentage, only 76, feel like it affects their quality of care. The last one, all patients in this practice are treated the same, regardless of race, economic status, or education. And what we see here is a little closer between I have this, which is about 82%, it's important to me, which is about 85%. But then again, it affects the quality of my care down here. And I think this is something that we have to face as we continue this idea of measures. We tend to talk about measures as assessing quality, but there is actually a difference between quality and accountability. Quality is whether or not the actions you are taking are in line with professional expectations and norms. Accountability is whether you are actually delivering based on professionally accepted standards and meeting the expectations of those that you're helping. They're not exactly the same, and they both matter. And it likely means that we have to get better with our language about how we talk about quality and accountability. As a last slide, I often get people saying, so, okay, this is all great, but what's next for primary care then? And I would say, you know what, this is our sidewalk and this is where it ends. This is where we are, and we have to decide what it is that we're looking over the edge and seeing. And I think one of the things that we're seeing is that it is powerful to have data, but we have to balance our data-driven decisions with the individual needs of people in front of us. If we strictly go by large numbers, then we gloss over the structural inequities that live in our society, which is why you can have a strange conundrum where equity is not seen as connected to quality. It is connected to accountability, and I guess I actually believe it's connected to quality too, but I have to listen to what people are telling me. What that makes me think is that we need meaningful accountability. It's one of the reasons we created our measure, but we need more like them. We need accountability that is about assessing whether we are getting the best professional value from someone, which is not always the same as customer service, whether we are getting the purpose and function of primary care delivered in a respectful and humane way. I think it also means that we have to think seriously about our tools and not confuse them with services. Telehealth is not a service, it is a tool. It is sometimes helpful and sometimes not, just like a stethoscope. Just because a stethoscope is good for some things and not for others doesn't mean we should embrace it only or never use it ever. It means that we use it when and where it is purposeful. The same is true of telehealth. We have to start to understand that of some of our tech tools, so we stop doing always all or nothing thinking around it. And the last is that none of it makes any sense if we don't have relational knowing. And this is really important. What makes a fact a fact? It's our ability to place it in context. The relational is what takes facts and makes them meaningful. And that matters for quality of care delivery. It matters for accountability. It matters how we understand the world around us. And we can't forget that we have to embed that in our practice. So that's all I have. I'm going to leave this slide up here very briefly so that I can make sure you see our funders, because I really am, I partner with them. They're good people. But I'll now open it up for questions.
Great, and thank you, Rebecca. That was an amazing presentation. So many things to think about. And I do invite you all to put your questions in the Q&A. I'm going to ask a few to get us started, and we have about 15 minutes, so we'll try to get through it.
I was hoping to leave us 20. Okay.
You did a great job with all that information. One question is just about your methods, and what makes you feel confident that the sample of practices and patients that you have is nationally representative or representative of the geographic localities or the types of practices that you're saying they represent?
Thanks. I get that question a lot. And what I say is, I have a canned answer now, which is to say we make a lot of policy decisions and a lot of research decisions based on NAMCs and on MEPS. These are national surveys that we're all very familiar with. The sample size for both of those surveys is about 280 to 320 clinicians, and it's sampled once a year. Our survey happened weekly and is now monthly, and we get an average of 800 respondents per survey. It's already 4 times the size of the surveys that we commonly use to inform policy. But when we look at each survey that we field, we see that their demographic characteristics represent the platform of primary care as we know it. Our surveys in each round have about 70% family medicine. They have about 20% rural practices. They have about 5% direct primary care practices. All the different ways that we break it down, we have about 35% small practices. They represent the demographics of primary care in the country as a whole. It is also heartening that when larger surveys happen, like the Commonwealth Fund or the Pew Trust, or Kaiser Family Foundation, when these larger surveys happen and they have samples of 14,000 and we have a common data point with them, the percentage or the findings that we have exactly match those larger surveys. So we have different ways in which we are able to check it, but we have every reason to believe that it is represented.
Yeah, I mean, there certainly is a lot of face validity, I think, for many of us who are working in the field and seeing patients in terms of the results that you're showing. I know that you have been using these data to move the policy debate, and I'm curious to know how you think what you think the impact of this has been on the policy debate, and then how you feel it should be influencing the research agenda.
Sure. On the policy side, I know that it's been informing. It has been used in over 200 media stories. And has appeared in the New York Times, Washington Post, CNN. It's gotten a lot of visibility, but visibility isn't anything unless action also happens. What we know is there are at least 8 states that have taken legislative action based on the findings of our survey. We get requests from the Joint Economic Commission, from Dr. Shoker, who is the White House COVID czar, the Federal Telemedicine Work Group. We have Virginia is an example. It's not the only one, but it's the one I'm most familiar with since this is where I live. In Virginia, we used our survey data, or we partnered with the Virginia Center for Health Innovation to use our survey data to get over 1 million units of PPE to practices free when people were having trouble getting it. We spawned a payment reform governor's task force here. I currently serve on it as faculty. Part of the way we were able to get that was we had data that we could use. And probably most importantly, the 2 things that happened were it brought the professional and board primary care societies together. Pediatrics, internal medicine, and family medicine. If you know this world, you know that's a rare thing. In fact, it's the first time they ever came together for anything. And they published a joint statement that's newprimarycareparadigm.org on primary care finance. That was a direct result of the survey. They've used the data, the AAFP and many of the other societies have used the data to lobby for things on the Hill. And lastly, the national, or I should say the US HHS Secretary Becerra has started an initiative to strengthen primary care. And we have shared our data many times with Judy Steinberg, who is heading up that effort in the OASH's office. So we use it a great deal and it has moved many things. I hope it will continue to do so.
So I guess getting to the sort of some of the things that we can do to change, and that might be more focused on research. There's a lot of questions that have come in now. Thank you very much. And a lot of them have to do with, well, I think it's interesting to line up the experience of the primary care doctor and the patient, and also the the external community and how all of these are interacting with each other. I guess, you know, what do you think in terms of primary care research? You know, what are the types of, have you thought at all in your organization about the types of research we should be focusing on to advance sort of the connection between primary care clinicians and their patients, but also the broader community, and how we can all work together more cohesively?
I have, yeah.
Yeah.
So we ask a number of times in our surveys about partnerships with public health or community organizations or grocery stores or pharmacies, what have you. And what we found is both that and this outreach that clinicians have been doing around social drivers of health. They have there's a professionalism that has grown organically. And I think we need more research at this point on the professionalism of primary care and what it stands for, because many of our policies and our payment systems do not match it. And what we found during the pandemic is when push came to shove, the clinicians cared less about themselves and did whatever it was that they could for their patients. I mean, you had people, first of all, healthcare is the fourth largest industry in our country. Primary care is its largest platform. And in 3 weeks, we changed our workflow from in-person to telehealth. I mean, that's an incredible transformation. We did it with no capital investment and no hope of a funding strategy for it. We simply did it because that's what kept the population safe. We show up to care wearing plastic bags and coffee filters because we don't have PPE, facing a novel virus for which we had no vaccine or treatment, and yet continued to show up and work extra hours and do what we could to take care of the patient population. There's a professionalism in that we need to examine. This is not a workforce that is motivated by getting an extra 3 cents per RVU. This is not a workforce that's motivated by, you know, meeting some threshold for a quality measure. This is a workforce that's motivated by how can I be there when and where for my patients. So I think that requires a tremendous amount of focus, and the relationship, the way that patients supported their practices, providing them with food and with homemade PPE and all sorts of stuff during the pandemic, shows that we need to understand that relationship even better. We saw a lot of partnering happening with public health and community resources. It would be good to do research into how that happens, because it was really difficult to do, even though we did it. So how could we do that better? But one of the most stark things that I saw, and forgive me if my language gets a little crass, it didn't matter if you were an independent practice, a rural practice, an FQHC, or a hospital-owned practice or a concierge practice. In the end, the patients got screwed and the doctors got screwed. So did you close your practice because you didn't have money, or did you close your practice because you got furloughed, or did you close your practice because the health system pulled in and redeployed you to another location? Didn't matter. In the end, the clinician suffered and access was reduced for the patient population. I think one of the things that stands out most is those categories by which we analyze things. What is an independent practice and what isn't? I don't think they're meaningful anymore. I really don't. FQHCs, we say you see one FQHC, you've seen one FQHC. Of course, there's a way in which they're similar, but if we're thinking about how do we affect quality of care, how do we take care of the population, it's not the holy grail of stratification. And I think we have to start to look at that a little differently. As a last thing, I think we also have to look at the work of primary care differently. We have literature, we know that if a primary care doc did everything they were supposed to do during an appointment, the appointment would take 23.5 hours. That's what we know. So if that's true, guess what? It's not possible to do. We have to start to accept that maybe, in fact, there is a utility and purpose to things like retail clinics and urgent care. And we could partner with them instead of seeing them as something we have to work against. So I would love to see research that looks at, you know, how do we have to create a primary care model that actually addresses the contemporary ways in which health is won and lost.
I think what you've answered one of the questions as to why patients might prefer to get care at a traditional clinic, regardless of where it is, because they're just more oriented towards that type of caring that you talk about. Yet
They care about it a lot. And, I know people think millennials don't care and just want convenience and love the tech tools, but we don't find that to be the case when we actually research it and ask. I think that's more of a stereotype than an actuality.
there is sort of the next step of that question is, and to respond to one of the other questions, is that said about the traditional clinics and being a place of trusted sources of care, it seems like you're saying that these clinics recognize, many of these clinical sites recognize that they need to do more. They need to be able to help people with these social services and social determinants of health that are becoming so much more prevalent, and people are much more aware of them, and they're much more acute than ever before. Yet many of these clinics may not really have the financial mechanisms or incentives to be able to do that, or they may not know how to do it. Do you see anything on either the policy side that might begin to support some of those more connected models of care, and or research that is being done that can advance that model of care?
I do, yes. I think there's a tremendous reason to feel optimistic right now. The National Academy of Medicine did the first consensus study of primary care in our generation. I was on that committee. Our report came out in April last year, and it has had tremendous uptake in effect already. The report offers many recommendations. It offers a definition of primary care that is based in relationships and teamwork, as well as individual clinicians. It offers suggestions for how to shift payment. It begins to lay out a roadmap of where we are to the sort of ideal state that we want to be in for primary care. And it is a treasure trove of literature and information. I highly recommend it. Anytime anybody asks me, do you have evidence about now? I point to that report because it really is in there. But as an outcome of that report, we have had many employer groups and insurers approach us about how do we get this to happen now? Can you help us walk through that? One of the recommendations was for HHS Secretary's Council on Primary Care. It would be the first time that such a level of federal involvement and coordination of primary care ever happened in the US. And they took it on. And the Secretary Becerra has created this initiative for strengthening primary health care, and has put Judy Steinberg, who is in the immediate office of the Assistant Secretary, to put this plan together. She has been collecting a tremendous amount of information. They are going to have a plan that they put before the Secretary in June of this year. And so we're actually going to find out soon what's going to happen from that, and the kind of support we're going to get. Everybody seems to be on the same page here, understanding that we need more resources. The one thing I think they don't understand, and if anybody out there chooses to be an advocate for primary care, I think they don't understand how much this workforce is in peril.
Yeah.
It's bad.
Yeah. I just want to, we're at time, and
Sure.
I could probably go on for much longer with questions and answers. And I hope I did justice to some of the questions. There were a lot of really great questions that I may not have really probed the depths of. But I want to thank you for a really inspiring presentation that gives us validation in terms of what we're all experiencing, and some food for thought about where we can go from here. I want to thank every one of you for participating in this webinar. We are hoping to have more webinars like this in the coming year. And so when you log off, there will be a survey that will ask you about what you liked about this meeting, and how we can, what types of topics we might present in the future. And we may even reach out to some of you to participate in some focus groups or interviews to try to determine what we can do to move the practice-based research agenda forward at UCSF. So thank you all very much. Thank you so much, Rebecca, and thank you, Saji, for all your support behind the scenes. And thank you, Ben Wallen from IT, for also supporting us on this first webinar. Thank you so much.
Such a pleasure. Seriously, thank you all for your support.
Right.
Take
Bye-bye.
care.